concerns among the Peruvian military was we need to keep an eye on this, and so they're using their caseworkers to collect this data on cell phones. We paid a commercial company to develop it. We also developed open source software to develop the same capability. The question is it cheaper to just buy it from a commercial source or to develop it on our own? And that's the analysis that we're doing in that Peruvian project. We're not there yet, by the way, on the analysis. So again, we've got a lot of people. It's a big business, $43 billion. We're interested in mHealth as a mechanism to preserve and promote health and soldier fitness. It's not Army unique. We have the same needs in the Navy and the Air Force and the Marines. And given our size, distribution, and diverse mission, I'm going to tell you about what the big Army is doing with cell phones, which again is another one of those perfect storm conditions. So I don't have to convince the four-star generals in the Army about why cell phones are so important. They're moving out even more than we are on this, as I'll tell you in the second half of my presentation today. But the other thing that's important, and I get into this a little bit, is we also see health diplomacy as a big part of what we do. So when we go into a country like Afghanistan, wouldn't it be great if we could leave behind some software that's open source to allow the Afghan national healthcare system to capture healthcare data on maternal fetal health, which is a big problem in Afghanistan. So that leave behind capability is something that we're looking at carefully. And we wrote an article in the Telemedicine journal last year talking about how this kind of technology can be leave-behind technology to promote better health diplomacy. So I'm going to talk about these 5 projects briefly, one on diabetes, one on using cell phones in the U.S., reaching out to Reserve and National Guard members that have traumatic brain injury and other illnesses, and they're really geographically remote from the clinics. I'm going to talk a little bit about the dengue fever vaccine trial. You know, what you got to realize is we've got this gigantic vaccine trial that's going to kick off in July in Thailand and the Philippines. We're going to enroll 6,000 patients that are Thai and Philippine background, and then we're going to follow them for 3 years. Well, can you imagine what the dropout is of those patients? We lose 20% after the first year. So how can I keep that patient engaged and in the trial so I can determine, this is a $1 billion effort with Sanofi Pasteur, the Swiss pharmaceutical company that's developed the vaccine. The Army put money into it. And dengue, as you'll see, is a big problem in the world. So how can we use cell phones to reach down to a population that's extremely savvy on the use of cell phones? The Thai has, I think, one of the largest text messaging penetrations in the world. And so we're very well suited and well positioned in that country to do this project. Then I'm going to talk about mobile learning, educational content. We talk about in the Army hip pocket training, where I just pull out of my hip pocket, and I got it right there. So what if I had on my cell phone everything I need to do when I'm out there in Iraq or Afghanistan? How can I do hip pocket training if I'm with a public health service, for example, in the U.S.? Same kinds of projects I'm talking about, I think, has all important civilian relevance. Clearly, Text for Baby, which we're just a participating organization. How many here have heard of Text for Baby? Okay, not as many as I thought, maybe 5% of you. Text for Baby is a really important project that you all can get involved with right now throughout your healthcare members to get your recently diagnosed pregnant mothers enrolled to provide better care for them. So let me break. I'm going to show you this project. This is the diabetes one, and my colleague at Walter Reed, Bob Vygorsky, put this brief together. Bob allowed me to present this at this meeting, but he runs our Diabetes Institute where I practice pulmonary medicine. And what they have here on their cell phone is they took video clips, and they gave 80 diabetics all cell phones, but only half of the diabetics had video clips on them that the patient was told to review. This is one of those video clips that we want them to watch. So, Mike, I may need your help here. So here's one of the nurses talking to the patient. So imagine you're the diabetic patient at Walter Reed, and you get this video text or video message on your cell phone as a reminder to make you more compliant in managing your diabetes. Oh, Mike, I need to hit this one. I'm sorry.
You know what I mean. Exercise.
So can you go back?
Did you know that regular exercise will improve your blood sugar levels by helping your body's own insulin move the sugar out of your blood and into the cells that need it?
Mike, let's go back and start that again. Because I love the beginning.
All right. When was the last time you did it? You know what I mean. Exercise.
Of course
you Did you know that regular exercise will improve your blood sugar levels by helping your body's own insulin move the sugar out of your blood and into the cells that need it? The end result is lower blood sugar levels. And if done often enough, regular exercise can also help replace needing medications that we use to lower your blood sugar levels. So if your only idea of exercise is looking for the remote to change the stations on your television, I suggest you move the remote to the furthest location of the house and get moving. Have a great day.
So I tell you, I wish I was a diabetic when I saw that the first time. I was getting, some, attractive woman talking to me about diabetes. Sounded pretty good at the time. But fortunately, I don't have diabetes. Oh, let me get back. Yeah, I'm sorry. I'm not used to this. Mike, if you could just walk me through there. I got a laser pointer in one hand, a clicker in the other, and I got a laptop. I'm not... At any rate, if you could get me back to where we were. That's the only video. Keep going. Okay, back. There we go. So again, this diabetes project, we've already closed it. We've done it. We've evaluated the data. I'll show you the data. It's only people with type 2 diabetes, adult onset, low-cost, simple intervention. We're trying to see how well we control their blood sugar based on a lab test called the hemoglobin A1C. That's a test that we use to look at how well someone is compliant with their medical regimen, their exercise, and their nutritional status. We're looking at the stress, diabetes distress. Are we making progress in the diabetic patient not being as distressed? And then adherence to blood glucose monitoring. You got to check your blood sugars in order to be effective. This was a one-year prospective randomized trial, 2 groups of adults, all with hemoglobin A1Cs greater than 8%. Again, that's significant. If you're over 8%, your blood sugar is not well controlled. The first group received, everyone got a cell phone, but the first group got cell phones with video and usual care. The second group only received usual care, how we would normally take care of that diabetic. We had 90 messages, and these are, this is content-rich information. Scripts are 30 seconds long. 6 nurse practitioners who actually take care of those patients were the ones sending those messages out. The videos were sent at pre-agreed times. This was a 12-month study. We sent messages for 6 months, but we monitored and collected data at baseline, 3, 6, 9, and 12 months. You can see here the usual care group, they only got the cell phone, but no video. You can see they started off with a hemoglobin A1C of 9. Remember, 8 was the cutoff. And you can see over time, after 12 months, they reduced it from 9 to 8.2. Those folks that actually got the video showed they had worse diabetes to start off with at 9.5 hemoglobin A1C, and they reduced it a little lower than the usual care, but not statistically significant. Now, here's the problem. What was statistically significant is the fact that those folks in the red who all got the video, only about half of them actually looked at the video. Okay? That's a problem, right? So even if you give them the cell phone, the other problem with the study, we started this study 3 years ago. And at the time, we gave them a cell phone, and they had their own cell phone. So this was set up for less than meaningful data, I think, because we were limited at the time. We got into this study too early. But nonetheless, when you do a subset analysis on those that actually looked at the messages, their numbers were even more compelling, because now it's sort of that effect is diluted by the fact that a lot of them didn't look at the messages. So the rate of decline was greater for those folks that got the tips, and the highest, though, among those people that actually looked at them. The intervention did not change their distress, and the approach could be modified for use in other chronic diseases, so heart failure patients, COPD, lung disease. The second project is one that is being done in collaboration with our commercial partner, Diversinet, and I know Mark Trickstead's here in the audience. If you have any questions from Diversinet, Mark is here to help, and Ivan is here as well, or is Ivan not here? There he is, okay. So again, here's the thing. It's called mCare or mobile care, and it's